spectrum of the disorders: degenerative, inflammatory, metabolic, and neoplastic. Okay, so for both bone and joints, I'll stick to the common conditions. I'll stick to the major conditions so that I avoid giving you too much information in a very short time. Okay. So we look at the bone. So bone and joints, we review the congenital disorder of the bone, inflammatory infectious diseases of the bone, and here we just deal with osteomyelitis, arthritis, TB of the bone. We look at the metabolic diseases of the bone. Here there are a bit many: gout, rickets, osteomalacia, osteoporosis, hyperparathyroidism, Paget's disease. And then look at tumors of bones and joints. Very common tumors, because there are too many. Just look at the very common ones, the one that BPharm students are most likely going to meet in their practice. Okay, so we describe normal bone, and that will be able also to be able to explain the bone formation, especially in relation to hereditary bone disorders. We'll be able to answer questions based on Paget's disease, basically metabolic bone disorder, osteoporosis, osteomalacia, and rickets. And on top of that, we still have bone infections, so osteomyelitis. We have benign bone disorders, and then you have malignant tumors of the bone. Malignant tumors of the bone, only one gives us problem. Most of the malignant bone tumors are metastatic lesions. Only one we think you need to know of a malignant bone tumor you're going to meet, and you're going to give those patients chemotherapy. Okay, so normal bone is essential in mineral homeostasis, calcium, phosphate, and even sodium. It houses the hematopoietic elements. The whole bone marrow is in the bone. It provides mechanical support for the movement. Yes, the stiffness is basically part of the endoskeleton. It protects and provides the body size and the shape. These ones we know, we did physiology. Okay. The normal bone has the organic matrix. Organic means living, so it has the cells, it has the type 1 collagen, it has osteocalcin, it has glycoproteins, and it has proteoglycans. These ones can be modified, these ones can shift. Then you have the inorganic matrix, which most of it is a calcium hydroxyapatite. It still has magnesium, it still has potassium, it still has chloride, sodium, and fluoride. That's very important in mineral homeostasis. Okay. A normal bone, so these are what normal bone has. It has cells, it has collagen. We'll see what will happen if you have a defect in type 1 collagen, or you don't have sufficient proteoglycans, or you cannot deposit enough inorganic matrix, the calcium hydroxyapatite. Now, the normal bone has basically 3 cell types. There are others that are in the bone marrow, but the bone itself has mainly 3 cell types. One is the osteoblast. Osteoblast is what produces the osteoid, the unmineralized bone. The organic part of the bone is produced by osteoblast. They normally have very high amount of alkaline phosphatase, and that's why this enzyme alkaline phosphatase is normally when you're evaluating for a bone disorder, we normally include alkaline phosphatase in the panel. A very high amount of alkaline phosphatase means a lot of bone is being laid down. Okay. Osteoblast also has PTH receptors, parathyroid hormone receptors, because they do respond to parathyroid hormone. And also they modulate osteoclastic function, but their main function is to lay down bone. In simple terms, they make the bone. Yes, they lay down the bone. Okay. Now, osteocytes, these are for bone maintenance. They are osteoblasts that have become incorporated in the matrix. They're not laying down now, they are actually part of the maintaining the bone structure. Osteoclast is the one for which resorbs. Basically, it eats bone. Yes, it eats bone. Yes, like when you have a fracture and there's excessive bone formation, that bone remodeling, that bone resorption is done by the osteoclast. High amount of acid phosphatase and collagenesis so that it can break down whatever has been made by the osteoblast. Okay, so that is basically the one that makes sure that bone is not excessively laid down. They tend to be multinucleated, as we are going to see. These are osteoclasts. So bone laying down, bone being maintained, bone being resorbed or bone resorption. Okay. So these are osteoblasts. These are osteoblasts. Immature, like this one is an immature bone. These are now the osteocytes that are inside a very tough bone already there. These are the osteoblasts. Sorry. Again, these are another osteoblast. The cells you are seeing here. This is what we call um, yes, this one's here. They're actually laying down this bone. So they are weaving the bone. So this is normally what you call a woven bone. This is mature bone. What we have here are the osteoclasts. They are large cells, they're multinucleated, they normally come from monocytes. And they're breaking down so that the bone now maintains the shape, so that you maintain the shape of the cell. That's what we mean by bone resorption. This is how bone looks like. And again, another definition that we need to introduce here is how a long bone normally is defined. A long bone has some definitions, like this is the femur. Yes, that is or the shaft. This is where near the epiphysis, this is where the growth occurs. The growth plate normally is around there. The growth plate is around there in the epiphysis. The border between epiphysis and diaphysis normally was called the long bone has the cortical bone. This is the cortical bone. This outer very hard section is called the cortical bone. What you are seeing here is part of the cortical bone. And there's a bit weak and a trabecular bone at the center or a cancellous bone. Trabecular bone. And the bone marrow is inside here. This is where the bone marrow is. This is a compact cortical bone. This is the medullary bone or the spongy bone. I'm bringing up this concept because the issue of where each of these either tumors or infections do occur will depend on at which location. Is it occurring in the cortex or is it occurring in the medulla? Is it occurring in the epiphysis or is it occurring in the diaphysis? And especially for tumors of the bone, the location normally is very important. If I see a tumor around here, then in a child, then I'm most likely to say that's osteosarcoma than if I see it around that region. Okay. So this description actually matters. And we'll see it as we go along. We'll be repeating it again and again. Okay. Yes, this is what we are saying. Yes, this is the periosteum. This is the covering of the bone. This is the periosteum. fibrous covering of the bone. You can see there are blood vessels there. Okay, then there are canals where the blood vessels run. Yes, so this is an osteon is if when you have all these bones with a central canal, that will be an osteon. Okay, this is another lacuna. Yes, this is another blood vessel. So this part, this is the compact bone. The whole of this is compact bone or the cortical bone. Then inside here now we have a spongy bone or the trabecular bone. Okay, so this is where the most of the bone marrow is. So when you're doing bone marrow, you perforate, the needle goes through all the way into the spongy bone. That's where you get the bone marrow. Okay. If you're looking at infections, infections can start here and pass through the blood vessels, which is hematogenous, and go all the way into the trabecular bone. A normal bone is actually what we call remodeling. Bone resorption by osteoclast is tightly balanced with bone formation by osteoblast. So there's almost a symbiotic relationship between bone resorption and bone laying down. If you lay down excess bone, you'll end up with very thick bone. That will give you a problem. If you resorb so much bone, you'll end up with a very weak bone. That will be a problem. So you must balance between resorption by osteoclast and formation by osteoblast. And this is normally done by through bone physiology mediated by some hormones, parathyroid hormone, calcitonin, vitamin D, estrogen, thyroid hormone, cortisol, and growth hormone. PTH favors bone being resorbed. So PTH favors osteoclast. Calcitonin favors osteoblast. Vitamin D favors both. Estrogen favors the reduction, actually it tries to block osteoclasts. Thyroid hormone is basically a metabolic enzyme, it's a metabolic hormone, so it tends again to try to block osteoclast. Cortisol increases osteoclast. Growth hormone favors osteoblast so that the bone can be laid down for the growth. So the effect of many of these hormones will be the effect of many of these hormones on the bone will be on the balance between, and that's normally what we call bone remodeling. Bone remodeling. Bone remodeling basically is a balance between the osteoclasts breaking down bone versus the osteoblast laying down bone. Okay, that's what we are saying. Parathyroid hormone produces a PTH. When there's an increased calcium, okay. Okay, let's start from decreased calcium. When there's decreased calcium, since low blood calcium, you increase PTH secretion. What PTH secretion does is it increases bone resorption so that it releases calcium and phosphorus. It's also going to increase formation of the calcitrol. And once calcitrol is formed, calcitrol also increases calcium. This is intestinal absorption of calcium. The net effects that PTH and calcitrol increase calcium. Okay. Net effect is calcitrol and vitamin D and PTH normally increase calcium, either by increasing release of calcium and phosphorus or increasing the absorption of calcium and phosphorus in the kidneys. Sorry, from the intestine. Okay. And in the kidneys, what calcitrol does is it decreases excretion of calcium, you increase excretion of phosphorus. The net effect again is that you maintain calcium. by increasing bone calcium breakdown from bone. You increase calcium absorption from the small intestine, and you decrease calcium excretion. Net effect is that PTH and vitamin D increases calcium. We'll see what happens if you have excess PTH. What happens if you don't have enough vitamin D? Now, bone formation, there are two types of bone formation. Intramembranous means you form a membrane, then you basically, the body forms a membrane, then calcifies it, drops in calcium hydroxyapatite, and becomes bone. So there's a direct bone formation without passing through cartilage. This is normally how flat bones of the cranium, small bones like the clavicle, the vertebrae, the wrist joint, and the ankle bones are formed. Okay. Typically like the cranium. So this is intramembranous. And you can see these are basically what we call the central part of the vertebra. Okay. Axial bones. Now, endochondral bone meaning you form a membrane, then you convert it to a cartilage. Yes, involved as the cartilage at the epiphyseal plates, at this plate here. These plates. So you form a membrane or form a structure, convert it to cartilage, then now convert this cartilage into bone. That's normally what is called endochondral bone formation. And this is what you see with the long bones such as the femur, the humerus, appendicular skeleton, appendicular skeleton. This is mainly part of the axial skeleton. We'll see where this one fits in. This is axial skeleton. Okay, axial skeleton. So this one from a cartilage first, this one no cartilage. Intermembranous endochondral bone formation. So let's look at the hereditary bone disorders. And here I think I only have like three main ones. Okay. I have four. I have what is called achondroplasia. Achondroplasia is a form of inherited dwarfism. It's autosomal dominant mutation caused by gain of function. It's normally called gain of function of a fibroblast growth factor receptor 3. And when you activate fibroblast growth factor receptor 3, what happens is that it inhibits cartilage synthesis. This cartilage that you need to make the bone, this part here. So this cartilage is not formed. So if this cartilage is not formed, the long bones cannot become a dwarf. So there's resulting in a decreased endochondral bone formation and premature ossification of the growth plates. Yes, premature ossification of the growth plates. So the long bones are shorter. Femur is short, humerus is short, tibia is short, fibula is short. Basically, you are short. The long bones are short and thick, leading to dwarfism with short extremities. But the cranial and the vertebral bones are spared because they are formed in a different pattern. Remember the pattern we're talking about, the cranium, the clavicle, the vertebra. This one is in a different pattern. Even their hands looks like slightly different pattern. So these ones grow normally because they don't need a cartilage model. Okay? So leading to a relatively large head and trunk. So there's a synchrony. There's a synchrony between the long bones and the short bones. Sorry, but the flat bones. These patients actually have normal intelligence. They have normal lifespan. They have normal reproductive ability. A very common cause of inherited dwarfism. There are other forms of inherited dwarfism, but achondroplasia tends to be the most common. The problem is at the cartilage synthesis. So only long bones are affected. Anybody knows this guy? Anybody who knows that guy? Compared to his wife, yes, head looks normal. The trunk looks okay, but the appendicular skeleton is actually very short. We say they are normally normal intelligence individuals. Yes. Yes. So because this is the reason here is because Koech knows him. Yes, Koech knows him. Normal intelligence, this is a very famous actor. Normal intelligence, normal lifespan, normal reproductive ability. Only that the appendicular skeletons are shorter because of the defective cartilage model of making bone. That is achondroplasia. Okay. The next one is called osteogenesis imperfecta or brittle bone disease. This is due to abnormal synthesis of a type 1 collagen gene. 90% of the bone protein is type 1 collagen. So if abnormality of type 1 collagen is the bones become brittle. There's normally a very little bone formation. There's very little bone matrix. Generalized osteopenia with brittle bones resulting in recurrent fractures and skeletal deformity. You also see type 1 in the sclera, so the sclera normally is thin and blue. You also see type 1 in the joints, so the laxity of joint ligaments, there's hypermobility of the joints. You also see this in the inner middle ear bones because the middle and inner ear bones are very important in sound sensation. So this patient have deafness. Is the same the enamel of the teeth. So again, even the dental formation is not very good. We end up with what's called dentinogenesis imperfecta. It's the same type 1 collagen we find in the dermis. So the skin tends to be thin, susceptible to easy bruising. Treatment, this is supportive. The problem is abnormal synthesis of type 1 collagen. There are so many types of osteogenesis imperfecta. I'm not going to bore you with the different this. There are several types. Autosomal recessive, autosomal dominant, but the problem is, in brief, there's either the type 1 collagen is not formed or there's a qualitative defect in the type 1 collagen. Osteogenesis imperfecta. The teeth looks abnormal, the enamel of the teeth looks abnormal, and even where here, this is a child with those looks like a recurrent fractures. There's a fracture there that has healed. There was another fracture here, so that the bone is weak. It is very, very, this is the cortical bone, very thin. This is the central part of the bone, very translucent, meaning the bone is soft and osteopenic, meaning there's no significant density. This one is a child that is born with multiple fractures already in utero. These fractures can occur in utero. And because they get recurrent fractures, there's normally limb shortening. They get limb shortening. Abnormality of type 1 collagen, giving you very brittle bone. This is a osteogenesis imperfecta. And because the same collagen is found in other tissues, we'll also have a sclera that is thin, we'll have joint hypermobility, you have deafness, necrotic, thin. Treatment here tends to be supportive. We don't have a current clear state for treatment protocol for osteogenesis imperfecta. And it varies from very severe. So the severity also matters. The next disorder Here now, the osteoblast has been left to just lay down bone. So the osteoblast lays down bone excessively, without the osteoclast actually modeling it. So here the problem is there's more bone being formed than the bone being modeled. So everywhere is just bone. Even in areas where the bone is not supposed to be very thick, the bone is thick. Because of a decreased osteoclastic function, you have decreased absorption and you end up with thick sclerotic bone. You have a generalized osteosclerosis. The long bones show what's called broadened metaphysis. I'm going to show you a picture. The autosomal recessivism type, you have infants, and because the bones are thick, they cannot bend. There's no tensile strength. So again, they are thick and they're thick but weak. It's like you're dealing with they're called what? With a pot, those earthen pots. Very thick, very hard, but very easy to break. Okay, very easy to break. So these children will have multiple fractures. They'll have early death due to anemia because here now the trabecular bone is not formed. Only the thick bone is laid. So the bone marrow is very little. So they'll have anemia. They'll have infections because they're not forming neutrophils, anemia because they're not forming red cells, and they'll have hemorrhage because platelets are not formed. They have some form of a bone marrow failure. Basically, the bone marrow is not being formed. The bone marrow has been overtaken by thickened bone. Okay. This is the autosomal recessive type. This is the malignant type, means this is the most vicious. We can have autosomal dominant type where there's a bit benign. Okay. Patient present with fractures, they can find mild anemia. The cranial nerves normally pass through holes in the cranium. They have some holes, what we call the foramina. So if these foramina are not formed or they are completely blocking, they're completely blocked, it means the nerve that passes through is also tightly tightly held. And that's where there's a nerve impingement. So that even the foramina that you are supposed to find in bone are not there. And the problem with this is normally you don't have osteoclastic function. Osteoclastic function is the problem with osteopetrosis or marble bone disease. Now, compare this. This one, if you see a white area, like in this white area, it means bone or something that is a radiopaque. Yes, so this one, there's no bone. This is soft tissue. This is soft tissue. This is soft tissue. This is bone. This again, this is bone. But now here, but the bone is very thin, and even you're struggling to see it. This is a osteogenesis imperfecta. The bone is weak. The bone is thin. Here, you're not even seeing the center of the bone. Everything is just bone. Even in the midsection that you are where you're supposed to know what's remaining as the trabecular bone. This is what's remaining as the trabecular bone. Everywhere else is just thick sclerotic bone. Okay, and even if you look under the microscope, you don't see the trabecular bone. It is just thickened, haphazardly laid bone covering the whole trabecula. Okay. This is a thick bone. This part looks slightly normal. You can see the cortex. You can see the cortex. You can see now the medulla function. Okay. Yes, this is a patient. This is a young patient. You can see how the head was. Thickened, embossed head. This is very thick skull plates. The sinuses are all thickened because we are not seeing them. So yes, and even here, thickened bone, thickened, much thickened bone. The osteoclast come from they come from the macrophages. So what you do, you just give them a new bone marrow. These macrophages will be formed, and then they'll convert to osteoclast, and then they'll start resolving bone. And now you can see our guy some years later. This is after transplant. Osteopetrosis, decreased osteoclastic function. Okay, I think those are the only three I had: osteopetrosis, osteogenesis imperfecta, and achondroplasia. There are so many other inherited bone disorders. We're not going there. Sorry. Metabolic diseases, basically now the issue of, again, bone resorption versus bone being laid down. Number one here is called Paget's disease. Paget disease or statitis deformans. Remember, there are several forms of Paget's disease. There's Paget's disease in the breast. Paget's disease in the breast basically is a ductal carcinoma in situ invading the nipple skin of the nipple. That is Paget's disease of the breast. There's also Paget's disease of the vulva, where you have carcinoma invading, sorry, not a carcinoma, is when you have valval dysplasia of the valval epithelium, severe dysplasia. That's still Paget's. Then you have Paget's disease of the bone, or the osteitis deformans. This one here is a problem with the balance between the bone being laid down and then the bone being resolved. It's just a bone that has gone crazy. At one point, too much is laid down. At another point, too much is being resolved. At some point, you have a mixed picture where some areas bone is being laid down, in some other areas bone is being taken away. Increased but disordered and structurally unsound bone mass. Yes, you have lost the coordination between bone being laid down and bone being broken down. Okay, very common in the European ancestry. It forms the skull, the pelvis, the femur, and the vertebra. Usually polyostotic. Polyostotic, when you say polyostotic, basically means multiple bones are involved. It can be mild. So there are three phases. Osteolytic phase means the bone is being eaten up. Mixed means bone part of it, the bone is being eaten up. The other part, bone is being laid down haphazardly. The other phase here now, the osteolytic phase, it means more bones being laid down. And because of this, bone being eaten, bone being laid down, you end up with bone pain. You end up with deformity. You end up, it looks like there's too much activity going in the bone. Too much activity. So when you look at the X-ray, the bones are thickened, they're enlarged. But there are areas of where they have been removed, lysis, and the areas where there's too much bone being laid down. This is just haphazard, unsound bone, increased, disordered, and sound bone, meaning the coordination between the bone being, you have increased alkaline phosphatase. We said if you see increased alkaline phosphatase means you have too much bone being laid down. You have too much osteoblastic activity. You have urinary hydroxyproline. These are just from these are components of a type 1 collagen. So there are a lot of type 1 collagen being broken down because again, there's osteolytic process also going on. Complications, AV shunt basically means the artery and the veins are connected. Because there's too much destruction in the trabecular bone, the arteries gets connected directly to a vein. The typical scenario, the normal scenario normally is you start from an artery, you get to an arteriole, you get to the capillaries, and then the capillaries now make a venule, and then you have a vein, and then the blood goes back to the heart. But in this case, arteriovenous shunt means you are shunting blood directly from the arteries to the veins, and this gives you what we call a high functioning state. Okay, high function osteosarcoma, because again you have disordered bone growth, and this disordered bone growth, eventually you end up with the accumulation of mutations. It can even give you other sarcomas. This is a Paget's disease of the bone, increased but disordered and structurally unsound bone due to a lack of discoordination between. Yes, so here at this you can see the faces here. Yeah. Here, a lot of bone is being eaten up. You can now say the cortex is much larger. This osteolytic phase, there's too much osteoclastic activity. At this phase, some part of the bone are being eaten up, some part of the bone are being laid down. This is the mixed phase. You have osteoclast, you have osteoblast, and there's a haphazardly arranged bone. At this phase now here, this is the cortical bone now, it's much thicker. This is the, so here you can see thinning of the bone. Here is a mixed pattern, but haphazard. This is mainly now bone being laid down. This is the osteoblastic phase. Yes, and if you look here now, a normal bone should have a cortex there. Should have a cortex somewhere here. Yeah. Let me draw it well. Should have a cortex there. Then there's another cortex there. And then the center here is the trabecular bone. This one is not there. This is just bone that is all over the place. You cannot tell the cortex, you cannot tell that. This is the, it looks like a sword. It looks like a sword. The books will tell you it looks like a sword, and that's what you're seeing here. In the tibia. The tibia. This is a metabolic bone disease. This is osteoporosis. Osteoporosis basically is decreased bone mass. The whole bone mass is decreased. The calcium, the hydroxyapatite, both the inorganic and the organic components are decreased. Fracture. This is what we see mainly with the postmenopausal women and the elderly. This is osteoporosis. There are two causes. It can be primary, it could be secondary. And the primary cause is due to estrogen deficiency. You can have genetic factor, estrogen deficiency. And the secondary causes, when there's immobilization, endocrinopathies, like excess thyroid hormone, malnutrition, corticosteroids. These are very common drug that can be that normally being smoking, alcohol consumption, and even some genetic disorders can give you a very thin bone. Osteoporosis is basically thin bone, osteopenia. These patients have bone pain, and they normally have fractures, either femoral, vertebral, and even distal radius. And when you do X-rays, the bone looks like it is transparent. There's general radiolucency, meaning the bones are very. Yeah. Bone density. This is a DEXA of the bone. The DEXA will show you a decreased density of the bone. Okay, because this is not a disorder of bone resorption, and this the bone laying down is poor. The uh, whole bone matrix is actually reduced. So this is not a matter of the discoordination between bone being laid down and bone being resolved. No, the whole bone itself has reduced, the density and everything has reduced. So you don't see any abnormal changes about bone chemistry. The bone chemistry basically means these tests. These are the tests we normally do when you want to check for abnormalities of the bone. And remember, like for Hodgkin's disease, increased ALP, because you have in osteoporosis, the labs tends to be normal. The diagnosis is not made on the lab. The diagnosis is made on the X-rays. So generalized lucency of the bone, and the macropsia are thin cortical and thin trabecular bone. The whole bone density is low. The bone mass is low. The labs are normal. Okay. Like this one here, the bone looks almost spongy. So this is the normal vertebra bone called a compression fracture. Yes, osteoporotic lesion, they're actually very spongy bone. Bone with osteoporosis are normally very easy to fracture. So these patients, especially the women, get a lot of femoral head fracture. So they get femoral head fractures, they get vertebral fractures, and they get distal radius fractures. And if you look at the X-ray here, this is a normal bone. Here, you are not even seeing the bone clearly. This is the thin bone there. This is a spongy bone, this is a spongy bone, this is a spongy bone. And this one looks like it has been compressed. It's not the same size as that. This one here. This is a compression fracture because the bone is very thin. That is osteoporosis. Osteomalacia, now the bone is there. The bone is being formed, but it's not being mineralized. And the mineralization, we say the mineralization is supposed to be done by calcium. So these are patients who most likely has some calcium metabolism or a vitamin D metabolism defect. So decreased mineralization of newly formed bone. A deficiency of normal metabolism, typically from vitamin D. The specific causes, you can have a dietary deficiency of vitamin D, you can have a problem with intestinal malabsorption, or you can have lack of sunlight, you can have a renal, or you can have a liver disease, because these are necessary for the formation of the active vitamin D or vitamin D3. Osteomalacia, we see it in adults. Impaired mineralization of the osteoid matrix, resulting in thin, fragile bones susceptible to fracture. In children, we see rickets. This is prior to the closure of the epiphysis. Yes, so we see rickets. So the bone and the growth plates are undermineralized. So you'll have skull deformities. Cranial taps is when the cranial bones are actually extremely weak, and you can actually press on them. Frontal bossing is when now, because of that weak skull, it protrudes out. Rachitic rosary is when you have a thickening of the endochondral junction. Oh, sorry, osteochondral junction. The osteochondral junction. Okay. Pectus carinatum is John's chest. Pectus carinatum. Lumbar lordosis is when there's an excessive the vertebra bends forward. Okay, bowing of the leg, bowed legs, and then of course you also get fractures. In adults, you can get bone pain, you can get bone fracture. And because this is decreased calcium level, ALP can be high because the osteoblast is making the bone, is making the matrix, is making the osteoid, but this osteoid is not being mineralized by calcium because there's no or reduced calcium. Yes, this is broad leg. This broad leg. Yes. Rachitic rosary is what you're seeing here. It looks like a rosary of the Catholics. Yes. That's why it's called rachitic rosary. You can see there's a swelling here, there's another swelling there, there's another swelling there. Costochondral junctions. Okay. So there's this bowing of the legs, and of course, there's lumbar lordosis, and they also have the chest swelling out like a pigeon's chest. That's normally what we call pectus carinatum. Okay. Osteolysis fibrosa cystica or von Recklinghausen disease of the bone. Basically, in this case now, you have excess parathyroid hormone. And remember what we said, parathyroid hormone activates osteoclast. So basically here, bone is being eaten up, accessing the osteoclast. And this could be because you have a primary disorder producing too much the parathyroid gland. The bone is being eaten up. And it's so much eating up that what now remains is just a collection of blood. All the bone in this place has been eaten up. What's just remaining here is a collection of blood. Okay? And this blood becomes brownish. And that's why sometimes in some areas you'll see them being called brown cysts. And you can see the teeth has been eaten up. Because in this bone, there's excessive bone resorption due to overstimulation of the osteoclasts. You can get bone pain, you can get bone deformities, you can get bone fractures. This is normally seen with the excess parathyroid hormone from a deformity, a disorder other than normal or hyperplasia of the parathyroid gland. Osteolysis fibrosa cystica. We are calling it cystica because there is formation of a hemorrhagic cyst. We are calling it fibrosa because bone is now being replaced by fibrous tissue. It's also called von Recklinghausen disease. You'll also meet this in soft tissue tumors. But this is von Recklinghausen disease of the bone because there's another von Recklinghausen disease of the soft tissue. So the so-called neurofibromatosis. So those are metabolic bone disorders. We have Paget's disease, we have osteoporosis, we have osteomalacia rickets, we have metabolic bone disorders. Secondary to even resulting from a renal disease. Okay. Bone infections. The bone infection, the main one is just osteomyelitis, which could be from bacteria or it could be tuberculosis. Just that. So you'll have pyogenic osteomyelitis. This is a bacterial infection, usually from hematogenous spread, but you also have direct inoculation of trauma or from a set of infection in the prosthetic joint. So hematogenous spread meaning as a patient has an infection somewhere and then it goes to the bone. But sometimes you can have trauma. Patient with the bone fractures like an open fracture or a compound into the wound. Or you have a joint infection going into the into the bone. The common organism, Staph aureus is the most common, but you can also get, yes, H. influenza, Salmonella, and Pseudomonas. Salmonella, we get it a lot in patients with sickle cell disease. You get this a lot of pyogenic. Pyogenic means pus forming, pus forming infection. Yes, of course, patient will present with features of acute inflammation. They'll have fever and there'll be swelling. X-rays can be normal, and then eventually you see what you call periosteal elevation. This is the covering of the bone being elevated, and sometimes you might see now an area where the infection is eating up the bone. Under the microscope, is suppurative inflammation, is pus forming. Yes, you will have necrosis of the bone, and the necrosed bone normally is what we call a sequestrum, and the new bone being formed, that's normally what you call an involucrum. Okay, you can for testing, you can do blood cultures if you're looking for hematogenous spread, or you can do a bone biopsy for the microscopy, and also bone biopsy for the culture. Okay, the treatment here normally we give antibiotics. Some may require surgical drainage. Yes, if there's excess pus. Complications, they can form a fracture. Yes, they normally fracture. This can go intraosseous, meaning this can go deep inside the bone. It gets localized inside the bone. That's normally what we call a Brodys abscess. And because this bone especially normally develop excess amyloid formation, amyloid protein formation. That's normally what we call amyloidosis. This infection can spread from the bone and get into the skin, form a sinus. You will have this being drained in the bone, is draining. You see pus coming from the bone and then passing through the skin. Chronic inflammation can be a precancerous state, and these patients can get squamous cell carcinoma from a persistent stimulation of the cells around that area. And they do get squamous cell carcinoma. Sometimes it can be so much that they can even get secondary osteogenic sarcoma. This is bacterial. The common organism, Staph aureus, and Streptococcus salmonella, very common in a sickle cell disease. And remember, for bone lesions, you must mention X-ray findings. X-rays are very important in bone. That's why you are seeing it for all these conditions, we are including X-ray. Not even CT scan, X-ray. Yes, you can see pus here. This is pus here. And this pus has gone there and now elevating the periosteum. So this is what you see on the X-ray, elevation of the periosteum. So when you do an X-ray, you see that part being elevated. Okay? But you can see pus all inside the trabecular bone. And this may have come from outside and then drained inside here. You can see this is a good tooth. This is a tooth that has been completely eaten up by infection. Here you can see an X-ray where there's something there in the bone. And most likely this is most likely draining. Now here you can see there's a central particular infection is right inside abscess without draining. It's forming whichever. Yes, you can see now this is a bone that has been eaten up, almost eaten up. Yes, completely. It's a very regular bone. So what this is what's trying to form outside. The bone, when you're born, this is the old bone. This is what we call a sequestrum. So when you go for surgery, we try to remove this and we preserve this. You can see here a bone that is really, really scarce. It's a scarred bone. It's not as straight. You don't see tropic osteomyelitis. Okay. Tuberculosis osteomyelitis basically the same. It's the first they have weight loss. And you do a biopsy, you see cascading granulomas. See granulomas with the bone destruction. And the common bone that has been involved is the lumbar vertebra. Tuberculosis osteomyelitis, the term normally used is a Pott's disease. Pott's disease is tuberculosis osteomyelitis of the thoracic or lumbar vertebra. Complications include vertebral compression. You can get fractures. You can get an inflammation. You can see this one has completely been eaten up. What's giving this patient this kind of a problem? This is Pott's disease, tuberculosis osteomyelitis. Okay. So those are the infections. There are so many other infections, but there are only those two. Pyogenic infection, pyogenic osteomyelitis, could be acute, could be chronic. Then we have TB osteomyelitis. Now, bone tumors are even easier because bone tumors, they tend to give us, even us at our level, they'll give you a lot of problems. The easiest way to remember them is, what is it forming? What is the abnormality that this thing is forming? Basically, when it's a neoplastic process, means there's some abnormality. Where's the abnormality? Is this tumor producing too much cartilage? Or is it producing too much bone? Or we are not, we are not sure what's being produced. There's some neoplastic process in the bone. Which one is it? So, cartilage forming. These are tumors that form cartilage, excessive abnormal cartilage. They can be benign, they can be malignant. Benign one, we call them some form of chondroma. So you have osteochondroma, meaning is forming bone and benign cartilage. Chondroma is forming only cartilage. Chondroblastoma is forming immature cartilage. Chondromixed fibroma means it's forming cartilage but also has some fibrous tissue. So both the chondroid matrix and the fiber matrix are benign, but they are benign. These ones are benign. When it becomes malignant, we add the sarcoma. So chondrosarcoma is a malignant tumor that's producing too much cartilage. Now, bone-forming tumors, it can be benign, it can be malignant. This benign, we call osteodysteoma or osteoblastoma. The malignant one, we call osteosarcoma. Sorry. If you don't remember very many bone tumors from what I'm going to discuss today, remember osteosarcoma. This one is the one that's going to give you a problem. And this is the one where patients will come to your pharmacy requiring treatment. This is common. This is very common at this age group. Okay, and you see it mainly in the metaphysis of the distal femur and the proximal tibia. This is where we were talking about the location. You can see where the location comes in. Where is it? So bone tumors, the location really matters. Is it in the epiphysis? Is it in the pelvis? Is it in the shoulder joints? Is it in the shaft? Is it in the diaphysis? That's what normally matter. Okay? So you have tumors that we don't know where they're coming from. We have a tumor that's producing too many giant cells. We call it giant cell tumor. We have a tumor that's producing some bone cysts. We call it aneurysmal bone cysts. We have a malignant tumor that we don't know the origin very well because the cells don't produce bone. The cells are not, doesn't even look that they are coming from bone, but they're there. they are malignant. So if I had to discuss, I would just show you osteochondroma because it's very common. I will discuss osteoblastoma because again it's common. I'll discuss osteosarcoma and just mention the rest in passing. Osteoma is benign. When we find in the skull, like this one you're seeing here, like that one you're seeing over there. Okay, benign bone-forming tumor frequently involve the skull and facial bones. Okay, so this is what you're seeing here. This is a bone right in a benign tumor. It's well demarcated. It's not invading the tissue. Most likely it's benign. This is the normal bone. This is something inside the bone. The same, yes, osteoma, benign producing bone. Osteoblastoma is slightly different. We are mentioning because normally it's painful and it occurs in young patients. And in young patients, you normally have to worry about the issue that this could be osteosarcoma. It's a benign, painful growth of the diaphysis of the long bone, of on the tibia and the femur. Pain normally is worse at night. When you give them aspirin, they do improve. X-ray, there's red surrounded by an osteoclastic rim. This what you mean that this is very thickened bone here, thickened bone, and then the sand forming osteoblasts. Yes, this is how it looks like. This is the intraosseous inside the bone. It's benign. It's benign. It's painful. We are only worried about it because that's the same age group we see with the osteosarcoma. Osteochondroma are normally what you call exostosis. They're basically protruding. This is the bone. Their ones are protruding. And if you see them like that, they're normally bony capped outgrowth. They originate from the epiphyseal plate. So normally around the epiphyseal plate. So you get, yes, firm solitary growth at the end of a long bone. They are symptomatic. They can cause pain. They can undergo malignant transformation, but rarely. If there are many, we use the term osteochondromatosis. They are forming bone. They are also forming cartilage. And that's why they are called osteochondroma. They are benign. Benign. And chondroma is just a cartilaginous tumor, but now it is inside the bone. Inside the bone. And that's again, X-rays matter a lot in bone lesions. Anytime you're mentioning bone lesions, anytime you're asked about a morphology of a bone lesion, it's good to throw in the X-ray features. You can see the difference between osteochondroma and enchondroma is where is it? If it is on the surface, center, it's not at the center. If it's at the center, the word we use is a enchondroma. If it is on the surface like this one, we use the term uses osteochondroma. Both of them are benign. Benign cartilage. Okay. Germ cell tumor, basically it has too many germ cells. That's why it's called a germ cell tumor. It's like it has too many osteoclasts. So they are osteoclastic like germ cells. It's a benign neoplasm, but it can be aggressive and turn up by the tumor. This is the tumor. Female more than male, peak age around 20 to 40 years, a bulky mass with pain and fractures. X-rays normally shows an expanding lytic lesion surrounded by a thin rim of bone. With this one, you have to treat with surgery. It's an aggressive, a few can metastasize, but this one will require surgery. And what you see are multiple osteonuclear stromal cells. Germ cell tumor of the bone. Yes, benign, but can be malignant. Yes. Osteosarcoma is the most common. The most common primary malignant tumor of the bone, male more than female, age around teenage, 10 to 25 years. Patients with familial retinoblastoma, these are patients who have two so a patient is born with only one normal RBG. Then they get a mutation and they lose both RBGs. So RBG1 in one chromosome absent, RBG number 2 also absent. So these patients also have a very high risk of getting retinoblastoma. Patient will present in localized pain and swelling, and the X-ray, you have elevation of the periosteum. We normally call it Codman triangle. You have a sunburst appearance because the tumor seems to be forming bone. Treatment normally is surgery and chemotherapy. So you give chemotherapy first, then now you do the surgery. Prognosis normally is poor. It is a terrible disease. One of those diseases that your young man should not have. Okay, because this one will require amputation. Okay, but this can be improved with aggressive management. Even and they normally like metastasis into the lungs and even to the heart. I've seen a heart metastasis. Okay, this is the osteogenic sarcoma, the primary osteogenic sarcoma. Sometimes you can get secondary osteosarcoma arising in relationship. Remember, we talked about Hodgkin's disease, we have talked about irradiation, we've talked about chronic osteomyelitis, but this one involved mainly in the elderly. So if there's one malignant bone tumor that you need to remember, that is a osteogenic sarcoma. Okay. Yes, this is the Codman triangle. You can see the elevation there, elevation there. Again, you can see the elevation here. All this is just tumor. And if you look at the tumor, this is it normally occurs around the tumor. The tumor has grown past the bone, gone into the soft tissue. Tumor all the way going into the soft tissue. Yes, involve the metastasis of the long bone, so usually around the knee, the distal femur and the proximal, and they grow microscopically. And plastic cells producing osteoid is malignant. It's a sarcoma that's producing osteoid. Doesn't matter where we find it, even if we find it in the brain. A sarcoma producing osteoid is osteosarcoma anywhere in part of the body. This is now in the bone. You can get extra skeletal, not confused with that. We are dealing with bone. There's a malignant, highly aggressive tumor producing bone. Chondrosarcoma, a highly malignant, we see it mainly, it can arise de novo, or it could be secondary to endochondroma. We talked about endochondroma, we talked about osteochondroma, and even Paget's disease. Male more than female, peak age is around 30 to 60 years. It's an enlarging mass with pain, swelling, pelvic bones. You can also find around the shoulder girdle. Microscopy, you see cartilage. Yeah, you see cartilage. You see a tumor that's malignant that's producing traction. I don't know whether this reminds you of how a popcorn looks like. This is the lesion here. It's in the pelvis. Okay. The 5-year survival is predicted by histological differentiation from grade 1 to grade 3. This is the tumor. Completely now destroying the bone. This is the normal bone. Okay. Ewing sarcoma, we don't know where the cells come from, undifferentiated cells, but they normally just fill up the marrow cavity. These are part of what we call the small undifferentiated round blue cell tumors. Again, teenage boys, and on X-ray, you see some layering of peripheral bone, and this tends to move into the soft tissue. The good thing with this, it responds much better to chemotherapy and surgery and also radiation, with a 5-year survival rate almost 75%. You are seeing this in a diaphysis, location being important. Okay, it's a white mass with necrosis and hemorrhage, and microscopy, you see sheets of undifferentiated small round blue cells. Yes. Small round blue cells. The most common malignant tumors in the bone is not primary bone tumor, are metastases. If you see a malignant bone tumor, your first thinking should be, is this metastasis? Before you say it's a primary bone tumor. And the metastasis can occur from prostate. Prostate lies going to the bone, especially to the spine, breast, lung, thyroid, all these three likes bone. The easiest way to remember is you draw a triangle. If you want to remember which bone malignant tumors likes going to the bone, you draw something like that. Here you have thyroid. Here you have the breast. Here you have the kidney. And here you have a prostate. Also remember the lung at the center. So these are the ones that extremely likes going to the likes. Metastatic lesions to the bone are much more common than primary bone tumors. The joints, there are two. There are two lesions in the joint. Two lesions in the joint. Yes, we have rheumatoid arthritis and osteoarthritis. The others we mentioned in passing. Then we have a gout. Infectious arthritis, almost the same as osteomyelitis. Even the organisms are almost the same. Okay? Osteoarthritis is basically degenerative joint disease. There's loss of articular cartilage with there's no to minimal inflammation. This is not an inflammatory condition. This is a degenerative condition. The most common form of arthritis. Risk increases with age. Osteoarthritis affects at least one joint in 80% of the people over 70 years, and especially mainly weight bearing. So weight bearing, this is the knee, this is the ankle, this is the hip joint. You end up with a joint stiffness, you have a deep aching joint pain, which worsens the repeated movement. So repeated movement, the joint gets worse. Decreased range of motion, the joints crack. And that cracking of joints in old age is basically osteoarthritis. That crackling sound, what we call crepitus. You can get sometimes joint effusion, meaning the X-ray here, you have narrowing of the joint space, bone cyst, you can get osteophytes. Osteophytes when you have new bones being formed next to the joint. Okay, and the pathogenesis here is mainly age or wear and tear of articular cartilage. But it can also be from a chondrocyte injury or abnormal collagen activity. We get it a lot with patients who are obese, or patients who had a previous joint injury, or patients who are diabetic, or patients who are hematorosis. The only thing we need to remember is here, this is not an inflammatory condition. This is a degenerative joint disease. This is osteoarthritis. Okay? So here now the joint is completely filled up. This is the joint space. This is the hip. The joint is almost like the joint has been ankylosed. It's anchored to the cavity. So the range of movement is very low. You get what is called Haberdine knots. These are knots. The knot, I'll show you again the knots. This one, you get the knots because there's a new bond being formed around those areas. And these new bonds are what we call osteophytes. Okay? And you look under the growth, but here it has chipped down. It's another bond system. This is the normal articular cartilage. Okay? That is rheumatoid arthritis. Sorry, osteoarthritis. Osteoarthritis. The next one here that also is common is called rheumatoid arthritis. And rheumatoid arthritis is a systemic autoimmune disorder. That primarily affects the joint of arthritis and also has extra-articular manifestations. The key word here is called rheumatoid arthritis because it produces rheumatoid factor. As common with most of autoimmune condition, very common in female, age 20 to 50 years. There's some genetic predisposition, including HLA, DR4 and DR1. So it's an autoimmune reaction. It could be triggered by an infectious agent in a genetically susceptible individual, like a patient who has DR1 or a patient who has DR4. These are MHC proteins. Normally, this one affects the hand, the wrist, the knee, and the ankle. So you can see here now, you're affecting the small joints, not the weight-bearing joints of the osteoarthritis. So you see it mainly in the small hands, wrist. You can also see it in the knee, but the hands and the wrist starts first. And the involvement normally is symmetrical, means if it affects both the left and right symmetrically, improves the activity. As opposed to this, which worsens with a repetitive movement. So this one is good in the morning, you don't feel it, but as the more you walk or work, it gets. There'll be swelling, there'll be redness, there'll be warmth of the interphalangeal joint. Because again, this is an inflammatory process. The X-ray, you see osteoporosis, you see bone erosion, you can see joint effusion. In the rheumatoid arthritis, in almost 85% of the patients. Okay? We have synovitis means there's inflammation of the synovium. There's a Pannas formation means there's a intense inflammation with the granulation tissue. There'll be fibrosis. There'll be bone, the joint will be fused. I mean, that's what we mean by ankylosing. Ankylosing. And then, of course, the joints also will be deformed. I'm going to show this in a picture. Okay? You can even also have what we are calling Becker cyst. And remember we said at the beginning here that also remember that it's a joint disease, but it also has a extra-articular manifestation, meaning it also appears in other tissues that are not joint. Okay? And in the laboratory, you see raised ESR, you see a raised antibody, so gamma globulins are increased. Rheumatoid factor is present in 80% of them. Rheumatoid factor is an IgG autoantibody against a patient's IgM antibody. You know what you're getting me. You have an autoantibody, which is IgG, attacking the patient's IgM. That is the rheumatoid factor. There are extrarticular manifestations like rheumatoid nodules, which you are seeing here on the skin. You can get other autoimmune conditions like Sjogren's syndrome. This is in the salivary glands and lacrimal glands. With neutropenia, we normally call it Felty syndrome. Or you can get rheumatoid arthritis that also presents with pneumoconiosis. Pneumoconiosis is when you have a lung silica in the lungs. Carbon inflammatory process, you might get amyloidosis. You can see the joint disorders like this one is mainly around the wrist joint and also it's a rheumatoid nodule. Okay. So again, this is inflammation. Inflammation caused by abnormal deposition of the immune complexes, attracting plasma cells, also formation of the antibodies, formation of the macrophages, and also formation in the introduction of lymphocytes. So it is an extensive deposition of the inflammatory cells. Inflammatory cells, there's a lot of deposition. This is the synovium. All this you're just seeing here are inflammatory cells. That's not this. Okay. And these are the deformities. This is the Boutonniere's deformity. This is the ulnar deviation. This is the swan neck deformity. Late stage of rheumatoid arthritis. This one you will read at your own pace. I'm going to give you the note so that people like asking that question. Okay. Again, the difference between osteoarthritis and rheumatoid arthritis. That question normally is a very common exam question. Okay. Seronegative spondyloarthropathy basically means this is an arthritis. Yes, it's an inflammatory arthritis, but it's not related to rheumatoid factor. So the term we use is a reactive arthritis or reactive spondyloarthropathy or seronegative spondyloarthropathies. Inflammatory could be autoimmune, but not related to, but it's rheumatoid factor negative. And you find this a lot now with the HLA-B27. These ones we are finding with the HLA-DR4 and the DR1. This is very common with HLA-B27. This group includes ankylosing spondylitis, reactive arthritis, enteropathic arthritis, arthritis that's coming from associated with the inflammatory bowel disease. And then you have psoriatic arthritis, and we are going to discuss psoriasis next week. This is a skin inflammatory disorder. Okay. Here, what they're trying to show here is this: the whole spine is fused. The whole spine is fused, and even these are the joints they are fused. These are the joints they are fused. These are the joints they are fused. Even here they are fused. They look like bamboo. So this is normally what we call a bamboo spine. And a bamboo spine we see with the ankylosing spondylitis. These are seronegative spondyloarthropathies. Another problem that can affect the joint is when there's some deposition in the joint. And deposition in the joint typically from gout because there's uric acid deposition, hyperuricemia, and the deposition of monosodium urate crystals in joints, with resulting form. The term we use is podagra, characterized by an exquisitely painful, inflamed big toe, heel, and the wrist. And when you do a joint aspiration, that's how normally we manage them. you see bifringent needle-shaped crystal uric acid crystals, because this is due to excessive deposition of uric acid. So this uric acid gets deposited, and then neutrophils come in. Now the problem with the uric acid is that they are membranolytic. So when they are swallowed by the neutrophils, they just pierce through the membrane of the neutrophils and come out. So neutrophils are trying to deal with it, but they cannot deal with it. The end result is you end up with what we call a frustrated phagocytosis. And once these neutrophils degenerate, they produce all those bad enzymes in the joint. And that's what's giving you what neutrophils are attracted. But this process can go on and become a chronic inflammatory process, where now these crystals are now being deposited in other tissues to give you what looks like a granulomatous reaction. There can be skin ulceration when you have a tophi. There can be destruction of the joints. And the complication typically is from joint destruction and deformity. Uric acid can form renal calculi, yes, stones, and also can give you papillary necrosis. Or so when your patient has acute gout, they have acute gout. What do? First, you give them NSAIDs. You give them something to block the effect of the flood. That's what's going to heal the diclofenac. Yes, fast before you try to deal with the levels of the uric acid. Colchicine is a drug that prevents microtubule assembly. So it prevents microtubule assembly. The need of a drug, these two are what we call uricosuric drugs. Uricosuric. Sorry, I'm confusing you. Probenecid is a uricosuric drug, meaning it will increase. Yes, allopurinol blocks the enzymes necessary in actually xanthine oxidase. So the uric acid levels are reduced. I've given you here a table for the classification of gout. It could be primary or it could be secondary. So when you eat too much meat, you have increased nucleic acid turnover, or you just have an abnormal enzyme that is producing too much uric acid or is lowering uric acid excretion. Because too much meat. Gout is common. Gout is common. The issue of meat and gout is because meat normally has a lot of nucleic acid. Yes, and this is where the uric acid is coming from. Okay. Yes, this is podagra. You can see the inflammation of the joint. Yes, another inflammation of the joint. Tophaceous gout. It has now formed a large deposition on the skin. This is now more of this. This is another tophi. This is now tophi when it is a cut. You can see this funny looking chalky material. This is a uric acid deposit, crystal of uric deposit surrounded by chronic inflammatory process, including a granulomatous reaction. Pseudogout, deposition of calcium pyrophosphate. When you aspirate the joints, you don't get the needle stick like needle shaped uric acid. Yes, and we see it a lot with the diabetes. You can see it with the rheumatoid arthritis. Pyrophosphate. Infections of the joints, arthritis. The same, just insert infection from direct inoculation, even from bone. Even the organisms are the same, gonococci, staphylococcus, streptococci, influenza. This is acute inflammation. Large joint actually the one that are affected, so the knee, the hip, and the shoulder. Okay, and when you spread the joint, you get a synovial fluid that has a very high neutrophil count. This is suppurative arthritis, and then you do Gram-Steiner culture. Do Gram-Steiner culture. You do joint aspiration, very high. So you do joint aspiration and do microscopy of the joint, a fluid. You see a very high neutrophil count. Yes. It may be from bacteremia. It could be by extension from an adjacent site infection like osteomyelitis. It could still be direct inoculation. This is suppurative arthritis. For the tumors and the tumor-like lesions of the joint, ganglion is very common. I'm just showing you because you'll see it. I'm very sure one of your relatives have complained to you that they have this around the wrist joint. It's a small cyst that is almost always located near the joint capsule or the tendon sheath. And most of them appear around the wrist joint, which appears as a firm, fluctuant, pea-sized nodule. And basically, it relies from it's not a cyst per se. It's you have a leakage of the synovial fluid into the tissue. This one here. I'm very sure one of your relatives has complained about having something like this on their wrist. Very common. But basically, it's there when you have a synovial fluid extravasating with a capsule and then swelling over there. Very common locations there. It can appear there. It can appear around there. Yes, very common locations. It's fairly innocuous. You cut it, remove the capsule, and then with the ganglions. Okay. The only other tumor that I know that can occur in the joint is called tenosynovial giant cell tumor. It's a benign cell tumor, it's a benign neoplasm that develops from the synovial lining of the joints. Also tendon sheaths and the bursae. It can be diffuse, meaning it's affecting the whole joint, or it can be localized, meaning it's well demarcated. That's what we mean by localized. Diffuse normally involves large joints like the knee. Localized tend to be in the smaller joints around the hand. It's a benign neoplasm of the synovial lining of the joint. It can also be malignant, but most of the time it's benign. The diffuse one can be malignant, can be aggressive, can destroy the whole joint. Okay, this is this filiform structure you're seeing here. This one here is coming from the synovium. This is most likely the diffuse type. Diffuse type. Tenosynovial giant cell tumor. This one, I'm not seeing so many giant cells, I'm just seeing mononuclear cells. Yes, this is the localized structures. This is the localized very normally around the small hands. And you can see it's being cut, it's coming out nicely. And once it comes out, it's localized. It's a very nicely rounded structure. This is the benign. It's a benign tumor. Any question?
Hello.
Yes, guitar.
I would like to comment on achondroplasia and dwarfism.
Yes.
How you are able to differentiate, especially when a kid is being born. Also,
Yes.
bone assessment is one of them to just check that the kid has normal bone. So I want to confirm whether it's something you can detect.
It will be a bit tough, but it will be easy to see. You will see a disproportion between the head. I know kids normally have bigger heads, but you'll see it that the chest. If you look at the chest, you look at the spine, yes, and you look at the bones of the head, they tend to be grossly out of disproportionately larger than the appendicular skeleton. You compare to the hand, that should be something. And then remember, we said this is a dominant disease, so it's inherited. So if you see that and sorry, guitar.
Yes, yeah, I'm getting.
Yes, and if you see that, then there's a family, but that disproportion between what we call the axial skeleton and the appendicular skeleton should point to that this patient might be having achondroplasia because eventually, as they grow, it will be obvious. It will be noted.
Okay, thank you. And then in terms of osteochondrioma and osteophytes, when
Yes.
they appear on the X-rays, I've seen orthopedic sometimes there's some confusion there. Because I think even I saw an X-ray should be last week, and from the landing day that was the osteochondrioma, but the doctor diagnosed osteophytes and recommended for a surgical procedure. Now, from my X-ray perspective, osteochondrioma.
Oh, that should be fairly easy. Fairly easy. Osteochondromas can be many. Osteochondromas tend to be usually one or solitary. So if I come here and I rub this, where's my marker? And I erase this. This one is occurring in the around the epiphysis, not on the joint. You see the location?
Yes.
This is the location. This is the joint. This is the epiphyseal plate. This is occurring around the epiphysis, not near the joint. The joint is very far. So I'm not going to call it an osteophyte. An osteophyte, I'm going to see, and even the age should matter. As on osteophyte, I see it mainly with the elderly and should be around joints. So, and the joint, also the context of the joint should have some osteoarthritic changes. So the joint capsule is almost closed. So this is the joint capsule, or this is the joint space. This joint space is minimized, it is small, it is closed out. Yes. So that context has to be there. Then now I'm seeing some swelling around the joint. Maybe that was just a typo because where was the joint disorders? Like now, if I see this, yeah, this could be an osteophyte. Yes, you can see here now the joint is gone. There's no joint here anymore. You are not seeing the joint space. The residual joint space is here. This thin area you're seeing. This is the joint space, but here now is like the joint has fused. So if I see, yes,
okay,
yes, the other is yes. Sorry,
this osteophyte, they have the same but they have the same bone, the same structure like the normal bone.
Not really. They are dense bone, and you'll not see the usual periosteal covering because they are not normal bones.
So when you yes, surgically.
Yes, if the degenerative changes are still there, they'll recur. The osteochondromas, no. Sorry, the osteochondromas, no. They don't recur. So this one I remove. This one you remove. You just cut here. It comes out very nicely. Just cut it there. So even in pathology, normally what we get here, we get this kind of a bone, and it's on the surface, so far away from the joint.
It's clear. It's clear to me now.
Okay.
Now, when it comes to osteoarthritis,
yes,
I've seen people are put on some supplement, vitamin D, chondroitin, and there's argument that you can regrow the cartilage, but some other schools of thought say you cannot regrow the cartilage. Others tell us that this supplement they help to stop the degeneration of the joint. When it's out the joint,
I don't think so. Okay. That's a very good question. I normally refrain from answering questions that are, being categorical, not answering questions, but categorical on medications that are either naturopathic or what guys call herbal medicine. Naturopathic meaning there's no exact science how they're supposed to work. So it could be one of those. They are given. Yes, even me, when I was a medical officer, I used to give those chondroitin sulfate. Whether they work or not, it could be the placebo effect, or sometimes they work, but I'm not sure how they work. In my opinion, I don't think they can work because with this kind of a joint, this is a joint that will now require hip replacement. This joint will not work. Doesn't matter how much medication you give. This one, you need to go in. Yes, remove the whole joint capsule. You remove the whole joint capsule. Cut the joint, the artificial, and bring in a new head that is also artificial, and this will not work. However much chondroitin sulfate you give.
Okay, thank you.
Okay. So, as I've said, this normally is a very common question. Please try to remember it. The issue of how to differentiate between rheumatoid arthritis and osteoarthritis. Any other question? If there are no questions, allow me to stop there. I'll share the notes for these final prints with the friend. Thank you very much. Have a nice day.